just as easily have been improving healthcare through strategic partnerships. And really, it's partnerships, especially as it applies to healthcare, I think are absolutely essential. But I think what's probably the most essential, despite the politics and all of the attention that healthcare seems to be getting in the media, if we really want sustainable healthcare, we're going to need leadership, project management, and quality management. And I think that the private sector is uniquely able to provide that in resource-limited countries as well as in our own country, as well as in Europe. And so this is the story that I'm going to talk about that talks about both my first experiences working in resource-limited countries, sort of, as the private sector guy working within a lot of public sector environments, but also sort of how that transitioned from a commercial training program to a non-commercial partnership with PEPFAR, the President's Emergency Plan for AIDS Relief, and then transition into some of the results that we obtained from that, and how I think that's very applicable to healthcare improvements that are needed in this country. And so this is me. I'm actually posing with 40 healthcare workers from Zambia. So this is up in the Copper Belt district of Zambia, it borders DRC, Ndola, Zambia. And there's about 40 other healthcare workers who are from throughout Zambia. So they're primarily supervisors in healthcare. And this is in 2004. So this is well after a decade of AIDS ravaging Africa through the 90s into the 2000s. And we're actually conducting a training program in conjunction with CDC and the Zambian Ministry of Health. The company that I was working for, BD, Becton Dickinson Biosciences in San Jose, had made arrangements with CDC and the Zambian Ministry of Health to develop a workshop, and it was on CD4 training. So CD4 is measuring essentially the ability of the immune response to mount a response against an infection. That CD4 cells are infected by the AIDS virus. You get a depletion of those cell counts, and the instrumentation and reagents that the company sells are able to give clinicians an answer with respect to whether or not this person needs treatment, or if their treatment's not working and needs to be changed. And so this was actually the first training of many, many more that were to come. And so this was called CD4 Good Laboratory Practices, the idea being that this is not FDA Good Laboratory Practices training, but it's mostly, how public health laboratories in Africa, Latin America, Asia would be able to effectively create quality results by effective specimen management, pre-analytical, analytical, and post-analytical issues that they could encounter. And so from this point, actually for the next 8 years, the company, through other trainers by the company in various countries, we conducted over 7,000 trainings over a period of 8 years in 61 countries. It was the largest training program of its kind. And after about 3 years, I got into the PEPFAR program. And this was in 2004. This is just when PEPFAR was enabling subsidies for drugs that could be used by AIDS patients in Africa, and being able to, and it was actually at this point beginning to roll out of the city centers and into the more rural areas. And so each of these individuals was responsible for a specific district in running HIV CD4 testing in their countries. But the challenges are great. In Africa, especially, in many parts of Asia as well, in Latin America, it's like a perfect storm. They have a lot of different issues that come around. For instance, there are very few doctors. And so if you look at this number map, anybody care to guess what the numbers actually represent? I know it's a bit far.
A doctor per capita per population?
Right, it's number of people per doctor. And so here, U.S. might have maybe 300 people per doctor. In countries such as Malawi, it's 50,000. So there's essentially no doctors, right? So practically speaking, it's very difficult to get good health care. and you are relying upon technicians and nurses, and allowing Tanzania it's very bad. And this world mapper map shows you the same kind of thing. You may have seen these where you can get information on any particular item. It looks at the relative number per country. So the bigger the country or the smaller the country's shape reflects, relatively speaking, and in this case, very, very few doctors in sub-Saharan Africa. You can see there's plenty of doctors in the United States. And what's also, so these tend to confirm each other, but if you look at HIV, so about approximately 75% of all AIDS cases globally are in sub-Saharan Africa, and this, I think, tends to show that. But HIV is a very complex disease, as you know, or AIDS is a very complex disease. You have different types of HIV. Of course, the patient can be infected by multiple mutations of the virus. You have complications with TB drugs and HIV drugs with TB. And TB is the biggest killer of AIDS patients in Africa. And you've got a lot of different organizations that are setting up programs. So there's a lot of programs underway, and it makes things very complex. In contrast, cholera is actually a very simple disease, but it's also a ravaging disease, deadly, of course. But it's a single bacterium. It can be easily identified if you have the right materials and equipment. And the medication is not as expensive as with HIV. Largely, cholera is an issue of, foods, water sanitation and sewage handling, right? And so the big issue in Africa is the fact that with, poor sanitation, poor sewage techniques, the rains come, the sewage drains into the wells, and the cycle continues. But what's also interesting is that if you look at both public health spending and private health spending, they're very, very low. And so, you wonder, well, gee, with the public health spending, since the Marshall Plan started after World War II, for all of the aid that's been provided just to Africa, and of course the Marshall Plan was covering Europe and a lot of other, but if you look at just the aid since then, it amounts to over $1 trillion. And yet there's not a lot of public health spending. And so you wonder, well, is it the economy? Is it the economy within these countries? Or perhaps are there more basic educational issues that might be part of the problem? And so if you look at this picture, and I'll talk about the BD-PEPFAR lab strengthening program. So if you look at the picture in the upper right, imagine that you are a parent in a small village in sub-Saharan Africa. Your daughter is running a fever. The fever is getting pretty bad. You decide that you're going to walk into town to take her to the clinic. You look, and they have a blood drawing area, and your daughter's being drawn by a person who may or may not be fully qualified. And you look at the floor, and you see needles on the floor, and you see some broken glass, and you see these wires stretched across the different furniture types. And you think, well, what is the problem here? It's obviously in disarray. The procedures may not be fully utilized. They don't seem to really care about appearance or quality. And so would you blame that on the technician? Probably not. Would you blame that on the manager? He probably has his issues too. But I think you would actually have to go pretty high up in order to really identify the issues in which causes the kind of malaise and inability to effectively manage healthcare systems throughout a country, much less a clinic. And so this was really kind of the point that PEPFAR made to BD when they said, would you be interested in partnering with us to try to help fight AIDS and TB in sub-Saharan Africa? They'd heard about the CD4 Good Laboratory Practices program. We had been partnering with different U.S. government partners. We had like 34 different organizations that we were working with at the time. And they recognize that the private sector has a lot of skills that are simply not found in sub-Saharan African countries. They see it with the distributors, they see it with the way companies operate in developed countries too. And so it was on that basis that they asked us to become an implementation partner as a memorandum of understanding that established the agreement. It was $18 million that would be shared, $9 million of in-kind contributions from the company, not cash, and also contributions in terms of funding from the government. And so these would all be managed on a per country basis. And so it was, the intention I think was originally to provide the support in 8 countries. We actually were able to impact 16 countries with multiple projects in Ethiopia, Uganda, Mozambique, and South Africa. There was a training center in South Africa where the additional 12 countries were also being assisted. And so this was all done by company employees. So we had employees in Puerto Rico, Brazil, Japan, Philippines, as well as Europe and the United States, mostly from the United States. And these were people, quality management backgrounds, or maybe logistics backgrounds, or maybe some TV technical experience that applied for these positions. And it was for them, it was really a great experience, but not only going to Africa, but also having the experience of working with people one-on-one and being able to provide assistance in their own unique way. And so if people would apply, we'd get like maybe 10 applicants or more per position. And so we'd actually go through a series of interviews each time, and there would be rounds of volunteers. But it was, for them, it was very exciting, and for the company, it was very exciting. Our program evolved quite a bit over the 5 years. So originally we were thinking in terms of, well, this would be on HIV and TB, technical assistance, serology for HIV titers and that sort of thing, and then also looking at, but we started getting into process improvements such as quality management and specimen referral systems, technology transfer using geographical information systems and GPS and data management, but then also getting into providing curriculum and other resources, program planning, and then also leadership and project management training, which was completely what we didn't expect from the beginning, because that wasn't in the original goals. In the original goals, it was to improve the quality of laboratory diagnostics around HIV, to implement short-term improvements in the quality of TB testing, but also to increase access to TB culture in accordance with what was then the WHO guidelines using liquid culture media. That's changed since then. But, and this is working with Ministries of Health, CDC, and a number of nonprofit organizations. And so I was the program manager of this program. And, but we had, year on year, we would conduct strategic planning sessions, and these would be like 2 days long. And we would bring in people from CDC, and sometimes on the phone we'd be bringing in people from Uganda or other countries, and as a part of the discussion. And so our newer goals, by year 5, and we were keeping the old goals, but our newer goals, we were challenging ourselves and deciding, well, we could be making big differences in terms of improving infrastructure. We could be making big differences in terms of improving the quality of laboratory systems nationally, as well as providing customized solutions for human resources. So we were enthusiastic. We were very ambitious, and there were many people within the company that were all over this. As well, by the 5th year, we had also agreed with PEPFAR that we should have a third-party assessment. We were pretty confident about how we were doing. And we wanted to know, okay, what happened? What were the inputs? What were the activities and the outputs? What sort of improvements did we make to quality? Is it replicable? Could this be done by another company another time? And is it sustainable? Is this something that is going to stick? Or is it something where, like a lot of instruments, they just sort of die on the shelf and rust? And so I'll talk about that more later. In the program management side of things, we were officially working in four different countries. We had 7 different projects, 16 countries that were impacted 41 different partner organizations that we were working with, a lot of nonprofits, NGOs in the country, but also nonprofits here in the US, like American Society for Pathology. 57 different company volunteers, and some of them would go back 2 or 3 times. 177 stakeholders that I was working with, not all at the same time, of course, but you know, different governments in different countries, and as well as the organizations that are non-governmental organizations. And overall taught over 1,200 laboratory workers in this process. And so we scaled up dramatically. We started up with about 3 trainings on 2 different topics in the first year, and then ultimately up to about 15 different training sessions and 7 topics by 2011. 2012 it dropped off a bit. I don't have the numbers on that, but that's because we were closing the program. Closing the program can take a long, long time. You want to make sure you got all your data together for the assessment. And the outcomes. So what I'm going to do now is just sort of talk about what were the outcomes, and then looking at more specific, serious impacts. So financially, the idea was that BD would be basically measuring, well, quantifying and documenting, you know, how much we were spending, how much we were contributing in terms of, you know, cost of people, as well as cost of materials. We can't give cash to governments. That's violation of the Foreign Corrupt Practices Act. And but on the Uganda, Ethiopia, Mozambique side through PEPFAR, these were the amounts. They couldn't specify that these were actually the amounts that were being dedicated to the BD-PEPFAR program. When we started, we were told, okay, each of these countries would be setting aside a certain amount of money that would be matched to your program based on the project that you agreed to. And but shortly after it started, we found out that that wasn't going to happen at all. So this was the funding that was what they called for public health laboratory system educational improvements. It's much more general, but actually amounted to more than we expected. This was the amount that we quantified. In fact, we couldn't spend enough money. You know, we were gearing up to spending $9 million over a 5-year period, but we ended up actually only spending 7. And the problem was that, you know, we couldn't give cash. You know, we had to be very careful as far as how we're handling contributions, even material contributions. It can't be directly to an organization. There's a lot of so-called NGOs, non-governmental organizations, that are actually tied in with the governments. In Uganda, for instance, Infectious Disease Institute is one. And so we would have to go through 2 or 3 different intermediaries and contributions that we would make to a nonprofit in the United States, and you would have an organization in, say, Uganda or Ethiopia that was able to place, say, specimen containers or computers and that sort of thing. And we were always, you know, gearing up for more volunteers, and so we're really kind of anxious to try to get stuff out there. But it was also, the challenge too was being able to get everything aligned and get the training programs started. And so that was another reason why we were having a difficult time spending money. In South Africa, the South African equivalent of U.S. STAMRIT, there's the National Institute for Communicable Disease, NICD, and it's sort of like TB Central for sub-Saharan Africa. They get, you know, referrals from many different places, and but there was a wonderful training center and wonderful staff that were there, and they worked with us and many other organizations. BD has within the company a lot of scientists, technicians who have expertise in handling TB to sell and market and service their TB products. And so we had great resources that were able to come in who were professionally trainers, and they're working with other professional trainers from other organizations. And the idea was bringing in groups of people so that they're not doing TB on the bench where, you know, when the wind blows, we're going to start getting bacteria distributed around the environment. And so there's different biosafety levels. There's like BSL-2 plus, which is sort of the minimum acceptable requirement, but it's kind of modified, and it's not, it would be barely adequate. One of the other, the training was really focused on trying to make it relevant for Africa. We also provided leadership training. So this was a center where they also had training in National Laboratory Strategic Planning for people who were working with ministries of health. And so because we saw that they had a leadership, it was just everything was death by PowerPoint. You know, after 3 days of other training topics that were around strategic planning, where it was all PowerPoint, the last day we did leadership, and it was great because there was no PowerPoint at all. I was one of the co-trainers, and we covered leading change, and we covered leadership communication, but also practices and best practices in leadership behavior. And it was a big hit. I think Martin Luther King Jr. Is an amazing speaker. His I Have a Dream speech, in terms of speaking, in terms of communicating, is extremely powerful. And we had, it touches on some different elements, but we had presented that and pointed out some of the factors that go into what made that a very impactful speech. There's symbolism, there's emotion, and so on. And so at the end of that, about a third of the group was crying, about a third of the group was laughing, and about the other third were saying, who in the heck is Martin Luther King Jr.? In Mozambique, we actually, because it's a Portuguese-speaking country, we had volunteers from Brazil, and they were amazing. We had 3 in particular who would go back again and again. So initially providing quality management mentorships to the person that's running head of the laboratories, but also later on providing audit instruction. There's different programs for laboratory management that PEPFAR was running, and these required huge programs. And so we were able to provide, audit instruction to help people be able to audit these laboratories after they've been trained through this laboratory management program that PEPFAR was offering. But we were also providing project management, so people could manage these programs. And that was something that wasn't being offered. So, CDC, it was interesting. When we started teaching on leadership and project management, CDC really wanted to have nothing to do with that. In fact, I was being told, you don't want to go there. Now, the CDC people in country, they were all over it. They were like, yes. The people working within the ministries and the NGOs, they were, yes, this is great. And we were describing what we could provide, and we provided it, and we were quite happy with it. So that was something that, affected my participation in the program later on. But I think it's very, so that's something that's noteworthy, I think. Let me back up a little bit. And so in Uganda, we started off in Uganda teaching laboratory quality management. And this was primarily for labs doing HIV testing. And our goal was to provide training for all laboratories at this training center in Entebbe. And it was a 1-week training. It was very comprehensive. And it was coupled with proficiency testing. So the proficiency testing, what that is it tests the lab. Is the lab able to do a CD4 test or not? And if they're able to do it well. So you send them a sample, and that sample has a known value. Or after everybody gets their samples back, you take the mean, and that's what you compare it against. And so when we started off, before we started off, there were about 43 labs that were enrolled in 2008 doing CD4 testing in Uganda throughout the country. And about 54% of them were actually able to give you a quality result. they passed the proficiency testing. By 2010, this was after the training, 96 labs were enrolled and 72% of them were passing. So we were able to up both the number but also the relative percentage of success. What was really exciting though was that in 2010, we received a report. It was a PEPFAR report. It's got the Country Operational Plan, COPS. And it basically talks about what the new plan is, but also what the results were. So the countries have to generate data and report that to PEPFAR, the Ministries of Health. And so we had learned that as a result of our program, that because laboratory testing was good enough that 100,000 people were able to get tested and treated for HIV/AIDS that would otherwise have not gotten treated. So that was some evidence that CDC was telling us, we haven't seen this before. So that was particularly exciting, a good thing, and we're actually making a difference. But I mentioned there's very few doctors, and the poor infrastructure, roads are frequently out in many countries, outside of the major cities especially, and no landlines. Of course, everyone uses cell phones. But also poor procurement communication systems. These are gloves that are drying. They're being reused, obviously. Our volunteers were working with the lab staff, and they were trying to find out, well, what's the issue? And the lab staff says, well, we ordered them, and we haven't been able to get them. And after some time, they were waiting and waiting, so they were having to rewash these gloves. It turns out the volunteers were able to find out, well, there was a closet space, and that closet space had boxes and boxes of gloves. And it's mostly just sort of a communication system, but these procurement systems and, what's the word? Looking at supply chain. The supply chain issues are a major hindrance. There's a lot of corruption within the central supply part within the government in these countries, in Uganda most definitely. But there's also just a great lack of education within laboratories on how to manage first in, first out, and order processing, and making sure you order stuff early enough. But I think what's really bad is not enough data. That's really, really bad. And the reason I say that is that people simply don't know, where the disease is. They don't know where the disease resistance is. So there are pockets of, and this is true in all these countries, where there are specific pockets where HIV can be extremely high, and other areas where it's not so high. And the same is true with disease resistance. So if you're going to do something about it, you have to be able to know where those people are. And so Moses Jaloba, who runs the TB Reference Center for Uganda, he had come to us after our success with the CD4 lab quality management program, and he says, there are all of these sites, these microscopy sites, where they're doing TB microscopy. If anybody can set a shot and have a business where they're looking for tuberculosis on glass slides, but frequently they need to refer it in order to culture it if it is positive, and we don't know where they are. And so we need to be able to identify these places, and we need to be able to interact with them. We need to be able to get their specimens back if we're going to be effective in terms of handling this problem. And so we had agreed that we were going to work with him, and he was working on a specimen referral system where, because 90% of the people are out in the sticks, right? They're not in the city center, they're out in the country. That if a person is sick and they need to have a diagnosis, it'd be great to be able to get their specimen to a reference lab, either regionally or nationally, so that it could be appropriately diagnosed and then treated appropriately. So, and here in the United States, it's like, 70%, I think, or 70-80% of diagnoses are actually based on a diagnosis, where it's more like 30% in sub-Saharan Africa. What we were able to do was to help to establish a geographical information and GPS system with Moses Jaloba. And so the outcome of that was that there were 153 specimens initially that had been referred to him in 2008 before we started, and they had about a 3-week turnaround time. So not including the time that it takes to culture it, if they need to culture it for a full 6 weeks. And I think that's the limit typically. By 2011, after our project with him had pretty much ended, they were up to 1,344 specimens referred with a 3-day turnaround time. So it was a dramatic improvement. I think a lot of it too is record keeping. I think the record keeping at the beginning just wasn't good. And so, as well, it was pretty successful, and he's a pretty visible guy. And so it actually, it meant that he was able to get new buildings. He was able to get WHO recognition, World Bank recognition. World Bank was able to provide him with a new building. WHO was able to recognize him as one of a few supranational reference laboratories for tuberculosis. But what was really important was that treatment for people with multi-drug resistant TB was now available. You know, WHO initially, their estimate of multi-drug resistant TB in Uganda was 4.3%. But that was based on just a survey, and that wasn't being updated very frequently. So, but through the specimen referral system, we're getting the specimens, we're actually counting them, and then we're testing them, and we know. So with an N of 100%, he was finding that it was more like 14%. It was 3 times worse than they thought it was. And this map actually shows sort of an example where the green, the darker green, represent districts where there's much more multi-drug resistant TB. The bigger red dot represents the site where there are patients that have this multi-drug at the lab site in the vicinity of that city or town. But I think what was particularly impactful here was not just knowing, you know, what it really was being able to know now where are those patients. Now they could pinpoint them. They were able to determine where those patients were that had multi-drug resistant. That then, there's a green light committee you may have heard WHO has for TB. So trying to minimize the extensive drug resistance. You know, they weren't issuing second line drugs all over the place. So in this case, they were able to be convinced that Uganda had a system where they could actually treat the people who needed to be treated and not create greater resistance. And so now, you know, whereas before it was a death sentence if you had multi-drug resistant TB in Uganda, now it's not. People can get treated. And so that was really wonderful. So we, you know, working with Ethiopia, we were able to leverage a lot of what we were learning from Moses. And in terms of his specimen referral system, how he had set that up, setting it up with the Postal Service where, you know, either truck or motorcycle courier carrying a big, like, cooler full of blood and TB specimens. And the provision of transportation containers and using the triple packaging system, international guidelines. And so we were able to apply training content. We spent a year developing training content for Ethiopia that was handling, you know, specimen management, laboratory quality management, but also in a sense sort of project, you know, lab management, right? Things you don't do in a lab. And it was a very comprehensive 1-week course that we had developed. And we launched that in conjunction with a GPS mapping program as well in Ethiopia. And within a year, the results were pretty remarkable. I think what was also really important to mention here is sort of the collaborative relationship. So, you know, with CDC and public health community, what, you know, we would call like a stakeholder meeting. They call it technical working groups. And so we were able to work with representatives there from Tulane, but also like University of Washington. These are all local people representing those organizations and many, many other organizations, including CDC, Ethiopian Public Health Institute, it used to be called EHNRI. But being able to work with them and come to decisions on how they could move together was something that was very new and different. We were crossing silos. we were breaking down the HIV, TB, malaria silos. In fact, the mapping, we were able to, get mapping information, this geospatial mapping, like our GIS, or ESRI. We were able to, share information. They were able to share information from us. The head of epidemiology for Ethiopia had put in one of those big, huge, 52-inch, I think, TV screens in his office because he was going to hook that up to his computer because he wanted to be able to see these maps and he wanted to be able to show it off. But I think, it's particularly exciting when you're able to see that kind of momentum. In Ethiopia, the public-private partnership had trained specifically on specimen referral systems, over 293 laboratory and postal workers. 554 health facilities are utilizing this referral system. This was as of a few years ago. It's continued on though. And I was reading a blog where I think the last blog I saw was from September of 2015. And they're continuing to build these maps in the region. So Ethiopia, like the US, they have a federal system, but they also have regions like states. And these states, these regions are very autonomous. So you kind of have to influence these regional heads, as you would have stated here. We were able to see enhanced access to laboratory diagnosis, decreased turnaround time, and increased the number of specimens decreased the number of specimens rejected. But I think what was really important here too is that we weren't another organization setting up yet another program. What we were doing essentially was we were strengthening existing programs. We were strengthening the TB program, we were strengthening the malaria program, but we were also able to demonstrate the integration through these technical working groups and having them take the ownership for it, which they wanted. So we weren't creating new silos. There was a case study in the Cardno assessment, and Gavin McGregor Skinner had written this particular piece where basically finding that this was important enough so that it really has to be part of the mainstream healthcare system where you're able to, through mapping specimen referral systems, which can also serve as those containers as they're coming back from the rural areas with the specimens, they could then be emptied and then you could put drugs, diagnostic, drugs, bandages, whatever, and that could go back to the clinics. So you're able to provide a system of delivery, but also who needs to be treated, and it'd be like issuing a prescription. And so it was, I think, recognized by this independent assessment organization that this was, very promising in terms of integrating programs and minimizing vertical. As well, I think recognizing that this is something that is huge in terms of epidemiology, but also for policy planning. If you have the information in terms of what the epidemiology is, if you could plan ahead as to where the monies need to go, whether it's private or public, I think that helps a lot. And so I think the impact overall in Uganda and Ethiopia is that GIS data enabled lab system managers to monitor quality improvements and epidemiologic data for disease prevalence and drug resistance, and demonstrates improved evidence-based health decision-making. And in fact, last I heard from the person that I was working with who was heading up the Ethiopia Public Health Institute was that their patients were actually being treated based on this information. So that was exciting. I think our strategic goals were met. The third-party assessment found that we were exceeding our goals. I think we gained a lot of trust and respect in a culture and countries where corporations are not well liked, typically. I think that for point of care, this is all very relevant for point of care as much as relevant for point of care systems, I think, as it would be for large instruments. In that, you by working with organizations and building trust, you're able to demonstrate tremendous value. There was, Alere actually has, I forget the name of their CD4 device, but the guy who was selling it in Uganda, a month before, he was the guy who was working for me as the program manager within Africa. So I was based here, he was based in Africa, and we were close friends. He left the company, he decided he was going to work for Alere, and I'm in this meeting with the Ministry of Health in Kampala, and Blum comes in, he's going to be part of the next meeting, and they're basically discussing how they were going to drop the BD products, and they're going to start picking up the Alere product. So it was pretty funny. But it was, they were very focused on making sure that the Clinton Foundation had the opportunity to have their say in terms of how the new point-of-care instruments were going to be validated. Some of the other issues that I had heard regarding point-of-care, Dr. Jane Carter, who's a hematologist based in Kenya, Nairobi. She's been there for 25 years, and she's been concerned about, proper use of controls. And she's been some hematology products don't utilize the appropriate controls, in her opinion, and that created, a great concern that she had in terms of making sure that the results were going to be valid. I know in Ethiopia that there have been malaria kits. It's like a strip test. And when it was first being used, there were so many false positives. People didn't really know that there were false positives until the company had to send out notifications, and that was well after the fact. So that was creating a big logistics problem and credibility problem for that company. So these are the kinds of things that, concerns that I heard with respect to point of care in sub-Saharan Africa. But I think also what was particularly exciting is that the person who was managing the program, the CD4, good laboratory practice there, no, the CD4 lab quality management program in Uganda, Agnes Nabasuri, she's the person in the middle. She actually did a great job of managing that program. And one of the things that she did was she went against the Ministry of Health, and she went against her boss, who is with the CDC. And despite the fact the ministry said we could not have any private sector labs attend the training, she made absolutely sure that all the private sector labs, as well as the public sector labs, got trained, because that was important to her. Because she knew that just a tiny fraction of the laboratories in Uganda were public sector. And from some numbers that I had heard, but they seem rather extraordinary, was that 90% of the laboratories in Uganda are actually private sector. But Agnes was, I think, heroic in basically being able to go against her boss, go against government, and basically have all of these other laboratories, because she wanted to have all labs. And we were quite interested in having all labs. But it wasn't until afterwards that I found out that this private-public thing was something that she risked her career and job for, but she got it to happen. And it was successful, which I think helped her out a lot. Ultimately, by the end of this program, she became, a person working with CDC in Uganda, a Ugandan woman. She became an extremely positive advocate of the private sector. And so she is now living in Washington, D.C. She got her Master's in Public Health degree here in Berkeley just a couple of years ago. And she had been looking for work in public health. And she's still trying to do that in Washington, D.C., but she also has colleagues in Uganda. And through her resources, financial resources, and through some people that she has hired who are working in Uganda, and property that she has there, they're actually growing Artemisia. They're growing the botanical that's used in creating malaria medication, anti-malaria medication. So she's got all this acres of land. She's growing like 200 kilograms of Artemisia botanical. And she's also bundling both rapid diagnostic tests for malaria, which helps to minimize any other parasitologic disease. You may think the person has malaria, maybe they've got a trypanosome instead. So it minimizes trying to treat a person who has a different disease than malaria. And so, but she's also finding that a lot of people in Uganda want to buy from the private sector because it's cheaper than buying it from the government. And so it's, she's got some amazing stories to tell, Agnes. And so I think, approaching this, I think as point of care or companies that are working in that space, there's sort of two different routes that companies go typically, and it doesn't have to be just these two, but there's sort of the corporate social responsibility where it's more philanthropic. It's generally not a big part of the strategy of the company, but they want to do well by doing good. And it highlights sort of the tensions between some of the social goals and economic goals. And I think that it's typically going to be there if the company does well. But if the company is not doing well, then they're going to pull back their social investing, what they call social investing, or their philanthropic funds. And different from that is sort of a more capitalist model, and that uses, it's humanitarian. It basically follows the strategic goals of the company. It's profitable. And the idea is that by working within the company, by working within the country and working with resources within the country that can be most effective and can provide the distribution channels that you want. And you may need to negotiate with distributors for quite some time before you get what you want. You're going to be more successful. If you're constantly bringing in resources from outside, that's going to be a waste of your bottom. That's going to affect your bottom line, and it's probably not going to be as effective. And so there's a whole group that's involved, FSG. I don't know if you're familiar with them, but they're advocates of this, what we call creating shared value, where it advocates capitalism, but also in the context of if you're working in resource-limited countries, that it can be a win-win. That really should be a win-win situation. And so doing business versus unmet needs. So here the y-axis is looking at patients, women receiving antiretroviral for prevention of transmission to the child, PMTCT. So hopefully the child will not be infected with the mother's HIV virus. And so that's one indicator, I suppose, of capacity. And on the x-axis, we're looking at ease of doing business. So there are some places like Ivory Coast, or of course South Sudan or DRC, where doing business can be very difficult. I was in Ivory Coast, and that was one of the programs that one of the countries that we were intending to start on. And shortly after my visit, we did some planning together. Our company shut us down because of security concerns. But this was a couple of years before they had a big political upheaval with all of the atrocities that happened from that. But this kind of gives you an idea of where the countries lie in that respect. The red line represents deaths due to AIDS since 2004 to 2012. And that line has gone down to about 1,200,000 annually. And so I noticed I didn't get a chance to update this chart. 2014, it's at 1.2 still. Now, historically, it seems like year after year, you can sort of predict that the number of people who die annually is about the same number of people of new infections for that year. This year, though, I noticed, 2014 actually, it was about double. So we have about twice as many new infections as the number of people who died from what I read. This was in the UNAIDS annual report. So that's a little disconcerting. But, and so you kind of wonder, is there more that could be done? There's huge amounts of money being spent by governments. Most of that is through the US government. But I think that there could be a whole lot more through the kinds of things that I was talking about, where it doesn't always have to be through tax dollars. And it's not always about money. Much of it has to do with skills. and just programs and how you implement things. So, there's point of care opportunities. You know much more about this than I do, I'm sure. You may know a guy named Salish Chitani, who I think was based in Seattle, and he uses ultrasound on a cell phone. And basically just hook up an ultrasound probe, and you could measure, ultrasound signals, and it would go to the cell phone. And you could then send images to a doctor. So having the huge infrastructure of a clinic and then, all of the people that are required to admit a patient and be able to, and the nursing and all of that for ultrasound, I think it helps to minimize that. Blood testing, I know there's a lot of different blood testing strategies. One's actually using light and actually completely non-invasive. There's a guy, he's an astrophysicist turned bioengineer. He's got a company in Colorado. He was educated at Stanford, but he uses like Rayleigh light scatter from light that basically penetrates the veins on your wrist and can presumably be able to measure specific elements without actually taking a blood sample. And so he presented this at a Bio2 Device Group meeting in Sunnyvale about a year ago. Pretty fascinating stuff. Outbreak monitoring, they have various ways you can use a watch or whatever, like a smartwatch, to be able to record specific events. If there's an outbreak of Ebola, if there's specific information that could be captured within countries. This, I think, is particularly important, so that it can be cataloged, mapped, responded to immediately. And so, I see all of this as, I think, part of a potentially new leadership model where the private sector is able to work with agencies, but other companies and NGOs to demonstrate working health system models. Using evidence-based decision-making models, driving the conversation by example. And I think some of what I've shown you, I think, is an example of that, where it would be sustained by the local private resources. And I think that ultimately is what is going to be sustainable if it's driven by the local private resources that are available. They're going to be able to make market-based decisions more cheaply. And I think that this also would apply to the United States in the context of sustainability. So these are areas where innovation could be applied in healthcare. The arrows representing, this is where commerce happens between health funding, health delivery, and technology. So developing new drugs and new diagnostics, those are going to be used in hospitals. Somebody's going to have to pay for it. But I think that, I think we should see increasingly, and this is, what I'm specifically interested in, is where pharmaceutical companies, diagnostic manufacturers, IT companies could provide a lot more than just their product. We could be potentially securing a lot of different kinds of strategic partnerships with different organizations where they're able to provide much more than what traditionally they provide. Academia, I think, would be a perfect example of being active partners in this area. I think, as well, economic models being used for healthcare funding. Really trying to identify, what is going to be sustainable, what is ultimately going to work, and not require trillions of dollars from funds from other countries that that people begin to resent. People want to be independent. So I think, to conclude, self-sustaining systems can be built by implementing process improvements with technology transfer and effective training through collaborative partnerships. The importance of effective stakeholder management in this cannot be underestimated. Private sector skills, as I mentioned, including quality management, project management, leadership, I think go a huge way in making these things happen. And that's it. So thank you for your time. go over?
We have time for some questions though, if anybody has any.
Yeah, I'm open for any questions, certainly.
So you mentioned how you met your goals and then you went further than that. You built some additional goals into the program, at least in the Southern African nations.
Yeah.
You really didn't spend all of your money. And sort of, why do you think what was so successful? What was successful? Were you, was it natural to extend these goals because of the time, or was it that you met the goals and you decided to put in stronger goals?
Well, over time, we decided, early on, we decided that, we could stretch ourselves. And there were one or two intermediary goals that I didn't put up there, but they were sort of along that way. I think that it was clear that we were going to meet our original goals. But we wanted to be we wanted to be impactful. We wanted to make it sustainable. And I think that, with the GIS, GPS, and combining that with specimen referral systems, I think it was huge in that it not only builds upon existing systems, but it is something that can be owned, and it's also scalable depending upon funding. So if all of a sudden the Congress decides that we're going to drop PEPFAR completely, or cut back severely, then I think that you can still manage a specimen referral system. It's going to be attenuated. It's not like you drop your instruments and run. I mean, you could still use them, and you're still able to, the box, the specimen container could last a very long time, depending. That's not the most expensive thing in the world to buy. A lot of it is just the process. It's the process that you've built and the procedures that you've established with other labs, as well as the regional centers and national centers. So that's what was important. But also the fact that this creates epidemiology in places, real epidemiology, in places where it was just frustrating because they still weren't able to really get people treated effectively. And and it's continuing on from a blog I read where they're now mapping in other regions, and so it's exciting for me recently to see that it's still moving. If you go to Direct Relief International, their website, DRI.org, I think it is, and you look for a blog by Andrew Schroeder. He was the guy who was working with us with Direct Relief International. And he's a good writer, and he talks about it. And the BD volunteers working with him. And so BD, unfortunately, doesn't talk too much about this. I don't know.
So you talked about how there were two kind of reasons companies might get into this, or at least at two extremes, with respect to, kind of enlightened self-interest and then corporate social responsibility. Where would you say BD was in this endeavor?
I think BD was more on the corporate. Actually, I think it was a bit of a blend. They had a social investing department. That was the part where that was the BD's fund that we could use to then provide contributions to nonprofits that would ultimately go to providing computers and such. But I think the company, they saw it as a strategic benefit. This was important to the company for growing the business. We know that Africa is growing dramatically in terms of commerce. This is an excellent opportunity to not just help grow business, not just be a vendor, like we did with the CD4GLP program, where we're becoming a big, back when I was working with them. I haven't worked with BD since 2012. But no, it was, I think it's being, being active, being a vendor, being a partner, not just a vendor. Yeah.
Just going from global to local back here, so you just touched a little bit upon it. Can you say a little bit more like what the private sector can bring into the healthcare system here in the U.S.?
Well, I think that, I think for point of care devices, I think it would go, the market is always going to be challenging, but I think, and I know that there have been point of care devices that have been intended to be inexpensive. But the idea is that if it's going to go to, say, an African country, that would be affordable. But I think that that is needed here, right? I mean, we have hugely inflated healthcare costs. Personally, I think Medicare has driven a lot of that. But I think that trying to provide that niche where you can provide a point of care device to physicians who are basically not paying through, they're not receiving insurance payments. Maybe they're avoiding that, there's these boutique physicians now, right? They basically get paid in cash by the patient, and they provide a lower cost service. So there's more and more of that. I think having them as your customer could be a great opportunity. And I think there's opportunities where economic models may be helpful in understanding how that can happen most effectively. But I think trying to identify as entrepreneurs that market and exploring and hopefully succeeding in that market. I think that could be particularly helpful for here.
Just to be just a little bit more broad, I was thinking like beyond just as you said, just being just the providers of a diagnostic, for example. What else, like based on, of course you had all the training part there in Africa, but is there something else that this company could provide here in the U.S. outside just the product itself?
Well, I think outside the U.S.
No, in the U.S. Outside the U.S. it's clear.
I think information technology. So, there are both laboratory information systems that are very expensive, and I think there may be some IT opportunities where IT companies may be able to work within a limited amount of scope at a lower price, provide specific benefit, and such as databases, but they may see an opportunity that is a specific niche. I think they may be willing to sell a product for less if they see where it may be able to grow into a bigger deal. So I think it would require, and I think working with academics, I think being able to really reach out and try to gather as much information as possible. I think that the extent to which your source of revenue is going to be market-based and not off of government grants would make it more sustainable in the long run. And you would know where that money's coming from. When I was working in this program, I know my colleagues, and I knew many of them pretty well with ASCP, American Society for Clinical Pathology, and American Society for Microbiology. They were always waiting to get paid, through Congress. They were waiting for these congressional reviews to occur, and they would wait months and months, and they would pause their programs because they were waiting for the funding to occur for the next PEPFAR round of funding. So it's in bits and pieces, and I think it happens on a quarterly basis. So it creates a lot of anxiety, it creates a lot of doubt, and economically, do you really want to be caught up in that? It would be a pain. I think you're not knowing where your check is coming in. And so, I think those are some thoughts that I can have on that right now.
I guess you mentioned that in order to get the money and resources out to Africa, you often have to go through several layers of nonprofits and other places so that there's no corruption.
Yeah.
That there's a lot of inefficiencies, resources lost or diverted just because you have to go through all these layers.
Right. I think mostly it was sort of time. You would need to get, like for instance, for Uganda, we were working with the Academic Alliance. They became another organization, but they were known as the Academic Alliance. They're based in Washington, D.C. They have a partnership with Infectious Disease Institute, which is in Kampala. IDI is tied in with the Ministry of Health, so, but IDI was getting a lot of funding from the Academic Alliance. So, it was like getting to know and working with and establishing a plan with Academic Alliance was one step, and then you'd also want to make sure that IDI was on the same page, that they were going to be able to, get this money, this process going through from Academic Alliance to IDI, and that ultimately that this would serve a specific need that would be relevant for the program, and meets also our stakeholder, which was also the Ministry of Health in Uganda. So yeah, it was a lot of work, and just a lot of early morning calls, and a lot of trips. Did I tell you how many trips to Africa over 8 years? 30 trips that I took. It was exhausting.
You mentioned the CDC, at least the US-based CDC, waived you off like leadership training, project management training.
Yeah.
Why was that, do you think, and how did that training contribute ultimately to sustainability of the programs?
So I think that it was political. Basically, the person who was in charge of this program for CDC, he had in his mind that we really don't want to impact leadership trainings or project management trainings in these countries. He felt that these are all sort of region specific. You can't train a leader here the way you would train a leader there in project management. Same. And so I didn't really buy into that. In fact, I'd explored it further. I heard what he said, and I acknowledged what he said, but, and I was, working with his lieutenants at CDC in Atlanta, trying to convince them that this is something that's truly valuable and needed. And by providing that training, you're enabling people to be much more effective in being able to manage programs. So if you're able to lead change, if you're able to have your guiding coalition, you've got your vision, and you've decided that, we need to follow this path, and this is how we're going to do it, and we're going to, you get people excited about it, and all of that is great stuff. But it really doesn't matter where you're from. We're all people, right? And so I think that he didn't really understand that. Ultimately, even if we had these trainings, and I was speaking in different places, and I was telling people about our results. And ultimately, at the end of the program, CDC decided that they didn't want me to be leading it anymore. And that BD, moving on with the next project, was going to pursue other things than project management or leadership. That was a big no-no. I had a new boss, and she felt that what I was doing wasn't helpful in that respect. I think that, in fact, later on they decided that they would, after I retired from BD. So, it's just political nonsense. And I don't really know why the folks at CDC felt that it was not helpful unless, this sounds crazy, but the only thing I can think of is that, we want to continue to keep the aid going. We don't want people to be completely self-sufficient. But that's a bit harsh. You see where I'm coming from there. Yeah. But no, I mean, the folks, CDC folks in country, and some of them were relatively senior. They were managing the programs for CDC in, say, Mozambique, and they were all over it. They absolutely felt that it was, what was going to be useful, because they were seeing where things, fall behind or programs crash, and, somebody's got to pick up the pieces again and again, and it happens again. fundamentally comes down to a lack of leadership. But I think also the economics of those countries have a lot to affect too. And whether or not they're willing to allow private sector. I'm not sure how long this will continue to be sustainable. I know for a fact from talking with people at high levels within the ministries in Uganda and Ethiopia, you know, they have no interest in seeing the private sector within those countries do well. They want to control them, but they want the public, perhaps, that they're in charge of, to be the ones that thrive. And they've told me that. So,
What a surprise.
yeah. But, you know, overall, I mean, there may be, you know, such an impetus here that they decide, you know, why should we kill this? If it's going well, let's keep it going. That would be common sense, right? I mean, that would at least, you know, so I think you could also argue that, you know, politically, if you kill a good thing, that's not going to be good for you politically if you're head of the Ministry of Health in Ethiopia. And, yeah, so, but yeah, it's a lot to think about. It's something that, you know, really changed my life a lot. And it's been a very rewarding opportunity. And you know, for a while, after I left BD in 2012, I was sort of looking for other companies that might be interested in doing this kind of thing and contracting with them. I think it's difficult to convince any CEO of a corporation to change their strategy if you're coming in from the outside. And so at this point, you know, I'm sort of more focused on what can we do to improve sustainability of our own healthcare system. And I think, like I was saying, despite all the politics, ultimately, you want to have a healthcare system that runs, that's sustainable, that is going to be market-based, and is going to be around longer. So, any other questions? Thank you for your time.